Hello, hello. Larry Vandegriff here. I'll start by apologizing about last night. We had some internet issues, and believe it or not, we're still having some internet issues tonight. So we're kind of working off of Plan B. So anyway, I'm going to talk with you tonight about the skeletal system, and then what I'm going to do is kind of follow the book. So if you're listening to this, please, if you've got your book with you, then go ahead and open your book to page 191. And at the very bottom, we'll start with the skeletal system anatomy. So I'll go ahead and give you a little warning. Any of these words that you see, like under skeletal anatomy, that's kind of in orange, like skeletal system, the axial skeleton, thoracic cage, appendicular skeleton, or whatever, any of those orange words are kind of where the test questions come from. So they're the kind of meat and potatoes of the chapter. So any of those orange words that you see, or anything in italics or whatever, those words mean things. So you can either do one of two things. You can either write them down, or if you want to, you can highlight them. A lot of people do that, and that's fine. Anyway, there's a lot of information in this, so I'm going to add some kind of need to know stuff and kind of explain a little bit of physiology about how things work. And anyway, I'll go ahead and give you a heads up. Be ready for next week. We're going to be covering a lot of chapters, so there's going to be a good bit of work next week. So be ready to go to work. So starting with the skeletal system, as it says here in the book, it serves many functions. So the first thing that it actually does, it provides support to bear the body's weight. So if you were only muscles or whatever, you wouldn't function very well. So you have to have the skeleton or the bones. Anyway, it establishes a framework to attach soft tissues and internal organs. It also protects the vital organs such as the heart and the lungs. So that's what the rib cage is for. So we'll talk a little bit more about it in a minute. Another thing in the very bottom here, in addition, the red marrow is found within the internal cavities of many of the bones, producing red blood cells. So we had always been told that the large bones are the major producers, especially the pelvis, produce a lot of red blood cells. So you have to have red blood cells for first of all, to carry oxygen and nutrients, and the red blood cells are also part of the immune system. So all of you being aware of COVID now, then the red blood cells, are very important. The other thing too, let me go ahead and mention, anytime you've got a break in any of these large bones, they bleed profusely. So I'll talk a little bit more about, especially the pelvis, when I get to it in just a minute. Anyways, you see here, the skeleton gives us a recognizable form composed of 206 bones. So please remember 206 bones. You will see that forever. And I imagine that probably would be a test question. So please remember 206 bones. So anyway, you've got the axial and appendicular skeleton or whatever, and we'll kind of talk about these as we go. The pelvis is where they both kind of come together. So I'd remember that too. Okay. All right, so you've got the skull, the facial bones, the thoracic cage, and the vertebral column here. This is part of the axial skeleton. And we'll kind of talk about the different parts of it here in just a minute. There's several parts. Anyway, two types of joints. So anyway, you've got connecting and supporting tissues, and we'll kind of talk about this in just a minute. But the ball and socket joint allows rotation and bending. So your shoulders are the ball and socket, plus also the hips. Then you've got a hinge joint. Your hinge joints are elbows and your knees. So they actually do flexion and extension. So here's some good pictures of both of those. So again, the shoulder and the hips are basically the ball and socket, and then again the elbow and the knees are the hinge joints. All right, you'll see the cranium here. So the cranium is made up of 4 bones, and we'll talk a little bit about those. The thickest parts of the skull is actually in the frontal bone and the occipital bone. Now I know all of you have seen the movies where people were headbutting each other, and that's okay, but it's probably not a good thing, because your brain inside of what they call the cranial vault kind of moves back and forth, and it causes a lot of issues with the brain tissue itself. And just to give you an example, Muhammad Ali ended up with Parkinson's disease, and the reason for that is he got hit too many times to the point that it caused brain damage, to the point that it gave him Parkinson's. So anyway, the thinnest part of the skull is the temporal bone, and just under that temporal bone is an artery, and it's very easy to rupture that artery, and you start having massive amounts of bleeding in the skull, inside the skull. So typically what happens, and it's almost happens with this scenario every time, is they get hit in the temple, it knocks them out, they wake up and they're kind of addled a little bit, or a little bit confused, and they'll start asking questions about what happened or whatever. Then immediately they'll go out and start having a seizure. So it happens almost with that same scenario every time if that artery ruptures. So you'll see the maxilla, which is just above the teeth, and this is where they call where you end up having fractures called Lefort fractures, and there's 3 different levels of them, and I'm not going to get into those right now. But you can actually have the frontal part of the skull that's actually broken out, and there's usually a head injury involved with that. They actually have to take the skin and lift the skin up and go in and kind of suture it back with metal wire to get it to hold together. Anyway, on the right side, you see the foramen magnum, and foramen magnum is very, very important. That's where the spinal column, or the spinal cord, and the brain actually attach. So there's part of the brain called the brainstem that actually comes out through the foramen magnum. If you have a head injury and you start developing what they call increased intracranial pressure, and what that is the brain swelling, it actually pushes or puts a lot of pressure on the brainstem itself, to the point where it actually cuts the circulation off of the brainstem. Now that's an issue once you lose circulation. The brainstem controls your heart rate and your breathing. So if it pushes it and pushes it and pushes it, puts so much pressure on it that actually tissue starts dying, then you're not going to breathe very well, and your heart's going to start slowing down. And what that's called is herniation, and it is not a good thing. Anyway, you'll see the occipital bone. This is kind of important. Just inside of the skull in the occipital bone area is the part of your brain that actually allows you to see. So there are 2 large nerves that start at the very back of your skull that come all the way through the brain itself to your eyes, or to your pupils. So, and they kind of cross. So these are very large nerves, and they're very sensitive to pressure. So one of the things that we will do is you look at their pupils. So if they end up having pressure, from a brain injury or whatever, what will happen is, and you can have pressure on one side, or you can have pressure on both sides, but being that they're very sensitive to pressure, what it does is it actually will cause that pupil to dilate, or you'll hear people talk about it blowing that pupil. So you'll hear this forever and ever. The pupils are a window to the brain, and that's the reason, is because of those large nerves being very sensitive to pressure. So this is, again, a little bit of anatomy and physiology of the head. All right. This is very important also. You'll see this forever, and I'll go ahead and tell you, you'll probably have to name this, or they may ask you on a test question how many cervical vertebrae there are. So anyway, there are 33 in the spinal column. So you've got 7 cervical vertebrae, there's 12 thoracic vertebrae, there's 5 lumbar vertebrae, 5 sacral, and 4 coccyx. Now, the sacral and the coccyx are both fused. but there's, they don't move very much. But the other part of it, the other part of the spinal column allows you to move and turn. So again, this is very, very important. And I'll go ahead and throw this out too. There are nerves that come out between the bones, and there's 31 nerves that actually exit the actual thoracic and lumbar vertebra, and the neck too. All right, so you've got 12 sets of ribs, 12 sets or 12 pairs of ribs. So again, you've got the heart, lungs, esophagus, and the great vessels. Now you'll notice the sternal notch at the very top, and then the manubrium. It's kind of a flat piece at the very top of your sternum itself. You can actually feel it. And again, you'll hear talk about the sternal notch. Those of you that have had CPR or whatever, then you're familiar with the sternum because that's where you're compressing. And then down at the very bottom, you'll see the xiphoid process. I'm assuming all of you were told in CPR to not do compressions on the xiphoid process because it ends up it'll end up going inward, and it causes all kind of issues like a lacerated liver, or you can puncture the stomach, or there's all kind of different things that can occur. All right, the very lower ribs, starting from 6, or actually from 6 on down, these are not actually attached. Now you'll see cartilage here, but all of those lower ribs are not attached to the sternum. So they're actually, sometimes some people refer to them as floating ribs, but you still can break them. So because they're not attached. So that's, if you're doing the Heimlich maneuver, that's one of the things that you want to try to stay off of. You don't want to compress these ribs too much. All right, we're going to talk a little bit about the different joint. We already talked about the joints a little bit, upper extremities, the lower extremities. I'm going to kind of go past this slide or whatever, and we'll kind of move on. So you'll see the AC joint, and you'll see the sternal joint. The clavicle is actually the collarbone. Very painful if you break it. Most everyone will, if they end up breaking their clavicle, they will hold their arm. They will not move the arm on that side. It's very painful. So what they'll hold the arm kind of like your arm is held in a cast or a sling and squat. So then you see the scapula itself. The scapula is one of the producers of red blood cells, and then also the humerus itself. So the humerus is part of the upper arm.
Looks like you've got 2 people attending live. If you
Okay, good.
Speak directly to Brendan McGee and Cesarina there.
All right, those of you that are live, if you have a question, please stop me, okay? So with the arm itself, you have two actual bones in the arm itself. You have the radius and the ulna. The radius is on the side where your thumb is, and the ulna is on the side where your little finger is. And these actually will move, and they will actually allow your arm to twist. All of you know that. So it's kind of a movable joint. All right, now you have the hand. So you've got the carpals, metacarpals, and the phalanges. You'll see these. And then we'll talk about the foot. The foot's similar, but it's a little bit different. The bones are named a little bit different. We'll kind of get to those in just a minute. But anyway, it is also a ball and socket joint. So then you've got your bones here. All right, we're going to talk a little bit about the pelvic girdle here. Now, this is very important. As I'd mentioned earlier, the pelvis is the major producer of red blood cells. So you also see the inferior vena cava and this descending aorta. These are both very large vessels. So frequently what happens if you have a crushing injury to the pelvis, the first thing these people can't do is walk, because the pelvis gives you form and allows you to walk, so that they would not be able to walk. That's the first thing. The other thing is, usually if one side of the pelvis is broken, it also breaks the other side. So for each crack in the pelvic bone, you lose 500 cc's, which is half a liter of blood. So you can lose up to, if there's 2 cracks, then you're going to lose a liter of blood just in the abdomen, and that's enough to put you in shock. If it keeps going, or it ruptures any of these arteries here, then you bleed even more profusely than that. So a pelvic fracture is a really, really big deal. So then you see the symphysis pubis here. You know, it kind of allows the pelvis to move a little bit, especially in a female if she's giving birth. And it does kind of move a little bit or separate, you know, shortly before she gives birth. All right, your femur is the longest bone in the body. Connects the pelvic girdle, you know, by the ball and socket joint or whatever. So you have the greater and lesser trochanters, or little bony projections kind of on the upper part of the neck of the femur that kind of stick out on one side, and one kind of lateral on the other one is kind of medial. And I'll talk more about those in just a minute. All right, then you have the kneecap and the patella. The lower leg, you've got the tibia, which is the shin bone, which is kind of in the front. And then you've got the fibula, which is kind of on the lateral side, or kind of in the back. And again, these are very similar to the radius and ulna. They allow your you know, kind of twist on your lower leg or your ankle. So the ankle itself is a hinge joint. We've already kind of talked a little bit about that. So you have 7 tarsal bones. And you have the tarsals, the metatarsals, and the phalanges, just like you do in your fingers. So the hand is the carpals, metacarpals, phalanges, the lower extremity or the foot is the tarsals, the metatarsals, and the phalanges. All right, a couple of other things about the skeletal system. We've already talked about it giving the body shape, protecting the fragile organs, allows for movement. Calcium is a big deal, so it helps store calcium. As you age, you lose calcium, and it's very common for older women, especially if they've had multiple children, for them to kind of be shorter than what they normally would be. I know of one lady who died at 102. When she died at 102, she was 4 inches shorter than she was when she was 35 years old. So it's because she had lost so much calcium. All right, I'm going to go past the musculoskeletal system. What comes up next is the respiratory system. All right. So this is a very, very good picture of the structures that deal with respiration. So please realize the respiratory system starts at the nose and the mouth, and it goes all the way to the terminal end of the alveoli. So this entire system is lined by what they call epithelial tissue. And epithelial tissue is mucus producing tissue. So all of you should know that from, you know, when you blow your nose, junk kind of comes out of your nose, or if you've got a cold or whatever, you start coughing stuff up. So what the mucus is actually doing is it's catching the impurities or catching any kind of pathogens or whatever that are either in your nose or down in your lungs, and actually is allowing you to cough it up. So it's kind of a protective kind of mechanism. The other thing that goes along with this epithelial tissue is it's very sensitive. So if you inhale something that's an irritant, then you start sneezing or coughing. The other thing that goes along with it is it's lined with very microscopic finger-like projections called cilia or cilia. It depends on which book you look it up in, the pronunciation. So anyway, these little finger-like projections kind of have a rhythmic movement that moves the mucus and the irritants up to where you can either cough it up or blow it out of your nose. And again, I'm not going to pick on the smokers, but I'll say this: if you smoke, it paralyzes these finger-like projections, and they don't work very well. That's why a lot of the smokers end up with a smoker's cough in the morning is they've lost that process of eliminating a lot of the smoke and the pathogens from smoking. So you'll see the nasopharynx at the very top. It's kind of in behind the nose, the nasal air passages, and then it kind of goes to the pharynx, the oral pharynx, that's kind of in behind your mouth. You see the epiglottis. The epiglottis is a little finger-like projection about the size of your thumb. And what it actually does is when you swallow, this epiglottis closes over the trachea and it keeps food from actually going down in your windpipe or down into your lungs. So anything that you get in your lungs, like water or any of the other stuff, it will cause you to have pneumonia. So the epiglottis is very, very important. The next thing you see is the apex of the lung. So it's the very, very top of the lung. And then at the very bottom is the actual base of the lung. So you'll see the trachea, and then you see it kind of coming downward or whatever, and you've got the carina itself. The carina is where the lungs split. So once it starts splitting at the carina, it splits 22 times until it reaches the terminal end of the alveoli. And we'll talk a little bit about the alveoli in just a minute. There is some gas exchange, and what I mean by gas exchange in the very lower part of the bronchioles. A little bit of gas exchange there, but most of the gas exchange occurs in the alveoli. So a couple other things before I talk about the alveoli is the lung tissue itself is actually kind of spongy, kind of like a sponge that's used to wash dishes with. So you can feel it kind of, I mean, it gives. So it's almost identical to a sponge. The other thing I want to mention before I talk about the alveoli is the diaphragm itself. It is a muscular, very muscular type organ. And anyway, this muscular organ is the important part of your breathing. So it actually moves downward, and your ribs, you have the muscles between your ribs, but it doesn't do very much about assisting you to breathe that much. It's the diaphragm moving downward and upward to create what they call a bellows, and you actually pull air in. And so anyway, if you have an issue with the diaphragm, then it's a huge problem as far as being able to breathe. The diaphragm is controlled by a nerve called a phrenic nerve that exits the neck or the cervical vertebra between 3 and 5. It actually comes down and actually controls the diaphragm itself. So if you have someone with a broken neck and there's pressure, one of the broken bones kind of gets over on that nerve or whatever, then immediately it'll make them to where they can't breathe. So the phrenic nerve is very important. All right, let's talk a little bit about the alveoli. The alveoli look very much like a kind of a clump of grapes. And the alveoli themselves are 1 cell thick, and they're enclosed by a set of vessels here. So you've got arteries and veins that actually closely adhere to the vessels or to the alveoli itself. The reason they're 1 cell thick is that way you can exchange carbon dioxide, which is waste, and you can actually pick up the oxygen. So it being 1 cell, it moves back and forth very, very quickly. So how quickly it works depends on if your body is under stress. Now, if you're sitting here listening to me, your heart rate probably is not that fast and your breathing is not that fast. So if you go outside and you run around the building a couple of different times, then guess what's going to happen? Your heart rate's going to increase because you got to pump more blood, but your respiratory rate's going to increase, and you've got to offload more carbon dioxide and pick up more oxygen. So the alveoli are very, very important. A couple of things with the alveoli. A lot of these patients that are dying of COVID, the alveoli become inflamed. they get full of mucus. And once anything that fills them or occupies that space, you lose that exchange ability. So I'm going to go ahead and go to the next slide here. So we've already mentioned this already. All right, a couple of things here. Adam's apple. Adam's apple's in the very front of your neck. So what you can, if you don't know exactly where it is, you can put your hand on the front of your neck and then just swallow, and you'll feel your Adam's apple move. The next is the cricoid membrane. It's kind of below the Adam's apple. And the cricoid membrane is I know some of you have heard of tracheostomies or whatever. This is actually where the tracheostomy is. And that's kind of a paramedic skill. So I'll talk a little bit about it, but we're not going to get that deep into it. So we already talked about the trachea and it dividing or whatever. It divides actually 22 times again. So we've already talked a little bit about the lungs already. So anyway, this is important, and you'll see this on a test. The right lung has the upper, middle, and lower lobes, so it has 3. The left lobe only has 2. The reason the left lobe only has an upper and lower lobe is because the heart is on that side. So it has to kind of make room for the heart. Now, you can have it be on the other side, where the left has 3 and the right has 2, and the heart is more on the right side. And you occasionally, there's 2 or 3% of the population that actually have their heart is on the right. That's called dextrocardia. If you ever hear someone talk about their heart being on the right side, that's known as dextrocardia.
What's the difference in mass between the two lungs? Is it significant?
They're the same size.
Okay, so it's just separated.
They're just separated.
Okay.
Yeah, just separated. That's all it is. All right, so we've already talked a little bit about the gas exchange. Now, this is important here about the pleura. A layer of smooth, glistening tissue that covers each lung that lines the chest cavity. Imagine, if you want to get kind of an idea of how the pleura feels, it's very much like saran wrap that has vegetable oil on it. It's about the same consistency as saran wrap with vegetable oil. Now, there's some fluid there, and that fluid is what I was referring to as the vegetable oil. You have to have that fluid because as you breathe in and out, your lungs are moving. If you didn't have that liquid there, what happens is with it moving, it would irritate and cause pain. Now, there are people who have pneumonia or whatever, they end up having what they call pleurisy. So infection can cause this liquid to kind of dry up. So if these people, if you're doing an assessment on someone having chest pain, one of the things you should ask them is, does your pain get worse when you take a deep breath? And if it does, it's a respiratory problem more than a cardiac problem. Because if your pain gets worse when you take a deep breath, that's not the heart. A heart attack is constant pain. Where if they're having breathing problems, if they take a deep breath and it hurts, that's pleurisy. So.
And that's just the absence of the fluid.
Yeah. But it's caused by an infection. They've had a bad case of bronchitis or probably pneumonia. Now, you could see this with COVID. It's fairly common with COVID.
Pleurisy.
Yeah, pleurisy. Yeah. All right, so here's your thyroid cartilage, cricoid cartilage, membrane, or whatever. Now, the reason this is called the thyroid cartilage, or whatever, is you have your thyroid gland around this. And so I'm not going to get very deep into the thyroid gland, but it's the thyroid gland is the control center for the body. So it produces chemicals and stuff that actually is in your blood. And it's actually called the master gland because it controls a lot of the other glands. So we'll talk about that a little bit later. So again, you see the alveoli, or then the main bronchi and the smaller ones or whatever. So again, there's millions of air sacs called the alveoli, and it's referred to as the terminal end, and it's where the majority, it's where 90% of the gas exchange occurs. There's a little bit in the small bronchioles. Small bronchioles are the parts of the lung right before it gets to the alveoli. A little bit of, they have the ability to exchange gas just a little bit, but the alveoli is the functional part of the lung itself. All right, so we've already talked a little bit about the diaphragm and how important it is, but you also have neck muscles. You have intercostal muscles, you have abdominal muscles, and pectoral muscles. Anyone who's legitimately having trouble breathing, they will lean forward. A lot of times they'll put their hands there. In fact, there's a picture in the book of a gentleman tripoding, so they'll lean forward or whatever, and this allows them to use their abdominal muscles and their back muscles to try to breathe. So they kind of get in a position where they can breathe better. So they also breathe through pursed lips. So their lips are kind of together and they're kind of blowing through their lips. So that's another sign of difficulty breathing. So the other part of it, I'll go ahead and say this to you. When you walk in and see someone breathing or whatever, look to see if look at their work of breathing. If they're having to really, if they won't talk to you very much, or they're talking in 2 or 3 word intervals or whatever, and then they have to breathe, that's a dire thing that's telling you that they're having trouble breathing. So look at just kind of watch them or whatever. And if they're breathing normally in and out, there's no issue or whatever, then there's not that much of a problem. But if they're really having to focus and their work of breathing is really hard, then that tells you that something's causing an issue with them. So you got to kind of figure out what it is. All right, well, inhalation, again, the diaphragm kind of moves downward, and their intercostal muscles contract, and they kind of lift the thorax or the thoracic cavity up just a little bit. The lung fills with air, and then there's what they call the respiratory cycle. Now, there's a thing, and this is kind of a paramedic thing. There's a thing called the IE ratio. And what the IE ratio is, I being inspiration, E being expiration. So it takes 1 second for you to breathe in. If you don't believe me, take a deep breath. It takes 1 second for you to breathe in. It takes 2 seconds for you to breathe out. Now, if you have asthma, chronic bronchitis, some other kind of emphysema, some other kind of breathing problem or whatever, the IE ratio may be 1 to 4, 1 to 3. So if you have damaged lungs or whatever, it takes a lot longer for you to expire than it does for you to breathe in. So that's another thing that you kind of may want to look at whenever you're actually assessing someone that's having trouble breathing. All right, so the diaphragm, intercostal muscles relax or whatever, and the thoracic cavity returns to its normal shape or whatever. So this is, again, the passive portion of the respiratory side. The active part of it is you breathing in. The passive part of it is breathing out. And again, it takes longer to breathe out than it does to breathe in. All right, this is important. You have several things in your body, and I'll kind of talk a little bit about them, that measure carbon dioxide. So in your carotid arteries in your neck, and then the aortic arch is very top of your heart, where the blood comes out of your heart and goes down to the lower part of your body. There are little receptors called chemoreceptors. And they constantly measure the amount of, now your book talks about cerebrospinal fluid too. But what it's doing is these chemoreceptors are measuring cerebrospinal fluid, but it's also measuring the actual amount of oxygen in the blood. That's what it's doing. So if now again, carbon dioxide is waste. So you're actually, and what these chemoreceptors doing are measuring if you've got a normal set of lungs, you don't have any breathing problems, it measures the carbon dioxide more than it does it measures the oxygen, but it measures carbon dioxide more than normal. more than anything else. Now, and I'll go, and there's an actual number that goes along with the carbon dioxide. You can actually measure it. The number can be anywhere from 35 to 45. Normally, the number is 40. So if you're producing more carbon dioxide or whatever, then or your body is sensing that there's the chemoreceptors are measuring your carbon dioxide being 50, then immediately it's going to increase your respiratory cycle, or your breathing is going to get a lot faster because you want to breathe that carbon dioxide off. We actually have on our cardiac monitors have there's a machine that goes with that measures what we call end-tidal CO2, and that's the amount of CO2 that you breathe out. A lot of people regulate their CPR based on that, so it's very important. But we'll kind of when everyone comes up to do the lab or whatever, we'll actually kind of show you this. It's a good way to tell if someone's having trouble breathing. So anyway, I'll go ahead and mention this. Your body talks about hypoxic drive. So what the hypoxic drive is mainly where you see the hypoxic drive is someone who's has emphysema because they've smoked for 40 years, or they worked in a coal mine, or they've been around some noxic chemical, for the majority of their life to the point where their lungs are damaged. What happens is the chemoreceptors, so if you've got damaged lungs or whatever, your carbon dioxide level wouldn't be 40, it may be 50. And that would be normal for you because your lungs are damaged and you're not eliminating it as fast. So what happens is the chemoreceptors get used to the carbon dioxide level being higher. So what they do is they stop monitoring the carbon dioxide level and start monitoring the oxygen level. That's referred to as hypoxic drive. So they won't increase your respiratory rate until your oxygen level starts dropping. So that's kind of how the hypoxic drive kind of works. But you don't see it unless they've got damaged lungs, and mainly from emphysema. Now, I'll go ahead and say this. There's not nearly as many emphysema patients now as there were back in the 70s and 80s. There were a lot of people, that was a big thing to smoke when they were younger or whatever, so everybody smoked. But there's not nearly as many people now with emphysema as there once was. All right, so respiration, and I'll go ahead and tell you, you will see this on test. You'll see this on test. Respiration is the exchange of oxygen and carbon dioxide in the alveolar tissues. So what it does, provides oxygen to the cells, removes the carbon dioxide. So anyway, the exchange that occurs in the alveolar level is diffusion. Now I'll go ahead and tell you there are some things that affect diffusion. If you were drowned and there were water in your alveoli, you've got COVID and there's mucus in your alveoli, it's going to affect that diffusion, because if something is occupying the alveoli, the exchange going back and forth is not going to occur nearly as quickly. Now, there's other things you can do. You can attempt to vomit. Instead of the vomit coming out, it goes back into your lungs and you aspirate, which is bad. The mortality rate from aspiration pneumonia is 85%. And the reason for that is the hydrochloric acid in your stomach. It actually causes a lot of damage to the alveoli itself. So I work for the burn center. So if we have someone who inhales superheated air and it goes all the way to the alveoli, immediately it starts causing swelling. And swelling, there's water that goes with it, fluid. So all of that affects diffusion. So anything that is kind of in the alveolar level or at the alveoli or is in the alveoli affects the diffusion. So it can't go back and forth and exchange normally. So we'll talk about this a little bit more. Right, I mentioned the brainstem coming out through the foramen magnum, whatever. It controls the breathing again by monitoring the carbon dioxide in the blood and the spinal fluid, whatever. So again, it's the carbon dioxide is the primary measurement that controls your breathing. Okay, and this will be on a test too. I promise you, this will be on a test. So I've already kind of talked about the hypoxic drive, and again, it kind of goes along with emphysema. So again, the medulla, which is part of your brain, initiates ventilation cycles or whatever. So it's also measuring the carbon dioxide. So anyway, the pons, as it says here, has two areas or whatever that. And the problem with this, if it helps augment the respiration during emotional or physical stress, is it sometimes causes people to hyperventilate, and that's not good. So you shouldn't do it very long because it causes you to start having pain and your hands will draw and all this stuff. And it's all from blowing off too much carbon dioxide. So. All right, so ventilation is simply, as it says here, moving in air out of the lungs or wherever the chest has to rise and fall. Now, let's talk a little bit about tidal volume. And you will see tidal volume on the test also. The tidal volume normally is about 500 in a normal person. And what I mean by that is 500 cc's or 500 milliliters. All right. So it says here the residual is the gas that remains in the lungs to keep the lungs open. So the tidal volume is about 500, but you only exchange 350. The reason this is important, there's 150 cc's or 150 milliliters that is called dead space. So where this dead space is air that's either in the nose or in the oral pharynx, in the trachea, in the small bronchiole. So it's air that's not necessarily being exchanged. So every bit of that 500 cc's doesn't make it all the way to the alveoli. So the normal person is only exchanging like 350. So you'll hear dead space forever. Okay. And in fact, I'll go ahead and tell you dead space is going to ask you how much it is, and it'll be on your test. So remember, tidal volume is 500, but dead space is 150. So you're only exchanging 350. Please remember that. You will see it forever. Okay. So this is stuff that you need to know. Again, I've already talked about the dead space. This is important. And you'll see this calculation on the test. So your respiratory rate, let's say your respiratory rate is 12 and the tidal volume is 500. Your minute volume is 6,000. 6,000 is a good amount, okay? So if you start increasing the respiratory rate and dropping the tidal volume, it affects your minute volume dramatically, okay? So minute volume is the amount that that's actually being exchanged in your lungs.
Respiratory rate is just breaths per minute.
Yes, respiratory rate goes up, the tidal volume will drop. Okay. So it'll get to the point where you're only exchanging maybe 200. That's not enough. Okay. But if your respiratory rate gets really, really fast or whatever, or your tidal volume gets to the point where you're taking just very small breaths or whatever, either one of those can affect your minute volume dramatically. So remember, respiratory rate by tidal volume gives you minute volume. Right? And again, the normal respiratory rate's 12 to 20. Your tidal volume is always about 500. Okay.
Oh, come on.
The technology, kind of
Hey, it's the internet.
like
See, I blame it on the internet.
you gain today.
So anyway, you have a regular rhythm or pattern of inhalation and exhalation or whatever. And then you'll have audible breath sounds on both sides. So that's one of the, as we get a little farther through, we're going to teach you how to use a stethoscope and actually listen to different breath sounds on both sides of the chest. Now, and the other part of it, is you can look at the abdomen. Is the abdomen rising and falling normally or whatever? Is it kind of pulling inward or whatever? Little children, if they're having a lot of trouble breathing, they do what they call retract. So what they do is they're creating such negative pressure, their stomach will really become concave and move inward, and their actual, because their chest wall is not very thick, their muscles or the skin will actually pull in between the ribs. That's known as retraction, and you see that all with little children. So, in fact, you might even see the test question: how do you know if a child is having trouble breathing? And if retraction is there, that's your answer. Some of you might see that at some point in time. All right, so we've already talked about labored breathing. Again, look at their ability to breathe. If they're laboring or they're really having to work hard to breathe or whatever, then that's a sign that they're having a lot of trouble or whatever. Muscle retraction. Now, you can see muscle retraction in adults, but it's mainly really skinny people. They have to be if you've got a very thick chest wall or whatever, and you're about 300 pounds overweight, you're not going to see retraction. I'll go ahead and say that, okay? In fact, I'm kind of picking on Josh a little bit. You wouldn't see retractions in Josh or me, okay? So anyone who's pale, cyanotic means a blue tint to your skin, and where you typically see these at is at the fingernail beds. So that tells you immediately, or sometimes you'll see a bluish tint to the lips. So that tells you that they're cyanotic. Cool, damp skin or whatever is another thing. Tripod position, already there was a good picture in your book, about the gentleman leaning forward in a chair and he's got his hands on his knees or whatever. That's a good picture of tripod. Agonal gas. A lot of people have what they call agonal gas right before they die. So that it's the body trying to make a last-ditch effort for them to breathe. I'll go ahead and tell you this: if you walk in and someone's making agonal gas or whatever, you need to be checking the pulse and probably looking at starting CPR, because they're going to need it very quickly. All right, we've already talked about what they're referring to here with the arteries, arterioles, capillaries, venules, and veins, or whatever. This is the exchange between at the alveolar level. So you've got the larger arteries; they become smaller and become the arterioles. Then they turn into the capillaries. And then you've got the veins that are large, and then you have the smaller venules or whatever, and they turn into cap. So that's where the capillaries are where the veins and the arteries actually meet, and that's where the exchange occurs. Okay. So you've got the systemic circulation, which is out all over the body, two different circuits, as it says here, and then you've got the pulmonary circulation, actually in the lungs. All right, this is a pretty good section right here, and I'll kind of stop here in just a second. You'll see your two lungs, and have you already covered this?
Passing blood to the heart and the closed loop.
So you've already covered this.
You're on a good roll if you want to keep going.
All right, I'll talk for a minute. So you see the two lungs, you see CO2, that's the carbon dioxide. The O2 is oxygen. So, pulmonary lung, capillaries, whatever your left lung or whatever. So what's happening is the blue side is the venous side. The red side is the oxygenated blood side. So what it's doing is it's circulating, into the lungs or whatever. So it goes in through the blue side, and it's oxygenated, and it turns it into red looking. So it's and in fact, I'll go ahead and tell you this. I don't know how many of you have heard this. If you cut your arm or cut yourself or whatever, you can tell by looking at the blood whether it's venous bleeding, because it will be darker. If it's arterial bleeding, it spurts. and it's very bright red, much brighter than what the venous side is. Now, if there is a lot of bleeding, it doesn't matter if it's venous or, then you want to try to stop it or pack it or whatever, and we'll kind of show you how to do this a little bit later. And I know they're pushing tourniquets like crazy now. And tourniquets work very good. I won't take anything away from them or whatever, but I will tell you this, and some of you are probably going to laugh about this, or you're going to say I'm stupid or whatever. And I mean, you wouldn't be the first person that's told me I'm stupid. But I've been a paramedic 43 years. And if any of you ask me if I ever used a tourniquet, I've never put a tourniquet on anyone. Never had to use a tourniquet. I was lucky enough to be able to get the blood to stop. Now I was close to putting a tourniquet. It was the
weekend nights at Grady.
Yeah. I was close to using a tourniquet a couple of different times, but I was able to kind of get it stopped. You know, so I probably should have used a tourniquet or whatever, but you got to realize back in the day that you had to make the tourniquet, so it was quicker to do something else.
Had to run for you dinosaurs too.
Yeah, you did.
Yeah, if the dinosaur bites the guy's leg off.
So you ain't safe.
All right, I'll talk just a little bit about the heart, and I'll stop after the slide. So the heart itself is a hollow muscular organ, just about your heart is about the size of your fist. So it says it's made up of specialized cardiac muscle, and the reason for that is it kind of generates its own impulse, where it actually pumps. So there are two paired pumps, or where you've got a low pressure side, which is the atrial side, and then let me back up. The right side is the low pressure side. The left side is the high pressure side. So you have two atriums that are the upper chambers at the very top, then you have the ventricles. So I'll go ahead and tell you this. The most important, no matter if it's atriums or ventricles, the most important ventricle, or most is the left ventricle. It does most of the pumping. But it pumps out all over, and it's the very thickest part of it. The muscle is very thick on the left side rather than the right side. So as we get further, after we've gone through some anatomy and physiology, I'll go ahead and tell you this, we're actually going to do a pig lab, where we'll actually have a pig heart and a set of pig lungs or whatever, and that way you can actually see the lungs themselves. You can actually feel them or whatever, and again, they're very very spongy, much more than what you would think. But we actually will dissect the heart, and you can actually look at the different parts of it. Whatever. The atriums, you'd think they refer to them as upper chambers or whatever, but all the atrium is a little appendage that just kind of hangs off the top of the heart. It's not a huge, big muscular organ. It's not much thicker. The atrial wall is not much thicker than a piece of paper. And they're just kind of hanging appendages is all that they are. You'll be shocked when you actually see them. Anyway, the right side, the right atrium, the right ventricle is kind of the low pressure side. The high pressure side is more not so much the left atrium, but it's more the left ventricle. That's the high pressure side that pumps out all through the body. So the reason that's important, there's a large artery that actually goes called the LAD, the left anterior descending artery or whatever, that comes down over the left ventricle. If you have a heart attack or a blockage in that artery and it takes out the left ventricle, these people don't do very well. They don't do very good at all. So what they do is every bit of the cardiac treatment now is aimed at trying to preserve the left ventricle, or trying to make sure that it survives to the point where it's not damaged. So and there's all kind of things that they do to go along with that. So, all right, I'll stop tonight.
You can keep going. Does anybody have any questions specifically about skeletal, respiratory, or the bit of cardiac that we've had so far? If anything, I would like to tell you next week, I mean, I've been babying you the first 2 weeks.